I'd like to introduce Dr. Philip Calder. He's professor of nutritional immunology at the University of Southampton, and he's had this position since 2002. He has a PhD in biochemistry from the University of Auckland and a doctorate in philosophy in biochemistry from the University of Oxford. For over 25 years, Dr. Calder has conducted research on the metabolism and functionality of fatty acids, with an emphasis on the role of omega-3 fatty acids in immunity, inflammation, cardiometabolic disease. Based on this research, Professor Calder has over 500 publications, and his work has been cited over 17,000 times. And I think that must be some kind of world record, I would think, 17,000 citations. I'll just add that we're all very aware of the central importance of chronic inflammation in the diseases of aging. So we're very excited today to be hearing from someone whose work is so closely aligned to the mission of the HNRCA. So I'll stop here, and with that, please welcome Dr. Calder.
Well, thank you very much for your kind introduction, and thanks to you for inviting me to visit and to speak to you. So the title of the seminar was a title I was given, I think, and I think it was based on a multi-author paper in which I happened to be first author, which actually examined the question in the title, which is about biomarkers of inflammation and how they might be used in human nutrition studies. So I'm going to deal with those issues in the first part of the talk, where I'll talk about inflammation, biomarkers, and something about nutrition. But what I would really like to do is talk to you about my love, which is omega-3 fatty acids. So somewhere at some stage, I'm hoping to get to a little bit about omega-3 fatty acids and cardiometabolic and inflammatory conditions. So inflammation is a physiological response to the presence of a triggering phenomenon. Most often we think about infectious triggers, so microbial components, but inflammation can also be triggered by tissue damage, metabolic stress, and other things as well. The link between the triggers and the response, of course, is the molecular and cellular pathways that are initiated by the triggers, acting through cell surface receptors that recognize the presence of these triggers, initiate signal transduction and gene expression responses that ultimately lead to the production or the change in the production of particular proteins and other chemicals involved in the inflammatory response. If you look at that sort of cartoon in a little bit more detail and try to work out what's going on in the response, of course you come up with something with an awful lot of information like this particular cartoon here. So here we have, for example, the bloodstream with cells involved in inflammation, leukocytes, interacting with the endothelial layer by virtue of adhesive interactions mediated by proteins expressed on the two sites that ultimately serve to tether and then draw the inflammatory cell through to a tissue location. In the tissue location, that cell encounters the trigger, it becomes activated, and in response to the activation, it releases many hundreds of different chemicals. It changes the expression of markers on its surface and what have you. Some of these chemicals act to attract more leukocytes. Some of them act to open the junctions in the epithelium to allow the leukocytes to come through. Some of them have other signaling roles, and of course some of them are targeted against the triggering agent. If all of this is working well, then the triggering agent will be dealt with and the system will return to homeostasis. One of the things that happens in inflammation, because many of these chemicals are damaging, is you get local injury which, if all things are working as they should, would resolve, and you get some tissue reorganization. Of course, that doesn't always happen. Then the other thing that's depicted here is that some of these inflammatory chemicals that are released at the site of inflammation spill over into the bloodstream. Now, this is useful in the laboratory because now you have a fluid in which you can monitor inflammation because of the appearance of these markers in the bloodstream. But physiologically and pathologically, what the biomarkers in the bloodstream or the markers of inflammation in the bloodstream are doing is they're going off to other organs and other tissues where they elicit, if you like, secondary inflammatory responses. So an example would be the induction of acute phase protein synthesis, like CRP synthesis, in the liver in somebody who has an inflamed joint in arthritis or an inflamed gut in inflammatory bowel disease. So inflammation at one site can trigger inflammatory responses at distal sites, skeletal, muscle, bone, liver, brain, and so on. The 5 cardinal signs of inflammation are shown here: heat, redness, swelling, pain, and loss of function. So these signs of inflammation are all mediated by the chemicals that are released as part of the inflammatory response. And of course, pharmacologically, we try to intervene by targeting these particular responses, which we do by trying to reduce the chemicals that cause those responses or to interfere with the signaling of those chemicals. Where inflammation is uncontrolled or excessive or continues unabated, tissue damage, metabolic changes, pathology, and disease occur. A good example of this is rheumatoid arthritis, where, in contrast to the healthy joint, we see the infiltration of inflammatory cells, the production of many hundreds of inflammatory chemicals, and the degradation of the tissue at that site, which results in the 5 cardinal signs: heat, redness, swelling, pain, and loss of function. Similarly, in inflammatory bowel disease, we have the infiltration of the inflammatory cells into the gut mucosa, the production of all of those chemicals, and the pathology that results. So inflammation is intimately linked with morbidity in many different disease states. Inflammation can also kill, and this is well described in this animal study published in 1993, where the effects of a normally lethal dose of lipopolysaccharide, bacterial endotoxin, were examined in wild-type mice or mice that had the TNF receptor knocked out. So all 6 of the wild-type mice died when they were exposed to LPS, but if the cells couldn't respond to TNF because they had TNF receptor knockout, they all survived. So TNF was intimately linked to mortality in this model. And indeed, you can also prevent mortality by administering an anti-TNF antibody or a cytokine like interleukin-10 that stops TNF production. So in this particular model, these animals are killed by a cytokine storm. They're killed by the inflammatory response. This sort of observation led Lewis Thomas to make this really nice statement, my favorite quotation about inflammation. Our arsenals for fighting off bacteria are so powerful and involve so many different defense mechanisms that we are more in danger from them, that is our inflammatory response, than from the invaders. We live in the midst of explosive devices, we are mined. So I think this is sort of putting a bit of a downer on inflammation, but it is accentuating the negative aspects of the inflammatory response. So I've talked about chronic high-grade inflammation where the patient and the doctor know ultimately that there's inflammation going on and they attempt to treat that. There's also silent inflammation. So a good example of this is the development of cardiovascular disease. So the build-up of the atherosclerotic plaque in the blood vessel wall, of course, involves classic inflammatory cells like macrophages and T cells that have infiltrated that space through exactly the mechanisms that I showed you before, and are talking to one another by virtue of the production of some of the classic inflammatory cytokines. So as so this inflammatory response within the blood vessel wall, which is silent, has a contribution to the build-up of the atherosclerotic plaque. Of course, later on, when the plaque ruptures and the individual has a cardiovascular event like a myocardial infarction or a stroke, that process also involves inflammation, again in the vessel wall, Here shown is the release of matrix metalloproteinases from macrophages that degrade the plaque cap and make it vulnerable to rupture. So again, plaque rupture and cardiovascular events are triggered by an inflammatory process. Another example of silent inflammation would be obesity, where the adipose tissue is infiltrated by macrophages, which are activated and start producing inflammatory cytokines of the type I've already been talking about, TNF, IL-6, and so on. And those inflammatory cytokines are believed to have a role in the pathology of obesity within the adipose tissue, but they also have distal effects on skeletal muscle, on the liver, and so on. And then the final example of silent inflammation would be in cancer, where the traditional 6 components of cancer, or described here as the capabilities to develop cancer, have been added to by a 7th, which is the presence of an inflammatory microenvironment. And this inflammatory microenvironment is believed to be now one of the 7 essential elements that are required for tumour cells to proliferate and cancers to develop and grow. So we see that inflammation is pretty important, that diseases and conditions that involve inflammation are widespread. Some of these are chronic, high-grade inflammatory components, but many of them have an element of what I've called silent inflammation. Of course, despite the nature of the inflammation, whether it's silent or not, whether it's in the joint or in the vascular wall, inflammation always has particular common components. Inflammation is normal. That was, I think, almost the first statement I made, but clearly in these conditions, the normal response is in the wrong context. It's associated with pathology. There's something about a loss of barrier function. That could be endothelial barrier, it could be epithelial barrier, inappropriate triggering, so loss of tolerance to signals that are normally not initiating a strong response, or lack of downregulation or resolution of an ongoing response. So, for example, the turning of an acute inflammatory response into a chronic response due to lack of resolution. They all involve tissue damage of some sort and loss of function, although the individual may not be aware of that, at least for some time. I've mentioned there are many common mediators, cytokines, chemokines, lipid mediators, matrix metalloproteinases, reactive oxygen species, and so on. And there are common signaling pathways like NF-kappa B, PPAR gamma. I mentioned before that the inflammatory response within a tissue results in spillover of inflammatory markers into the bloodstream. So we can measure inflammation by measuring things in people's blood. So we can measure acute phase proteins, cytokines, adhesion molecules, matrix metalloproteinases, activation markers on circulating white blood cells, and indeed blood cell counts and so on. So this is the background to this article that some of you have already mentioned to me today that was published in British Journal of Nutrition 2 years ago, where it's a pan-European activity where we were tasked with trying to come up with the ultimate biomarker of inflammation to be used in studies to substantiate claims on foods related to controlling inflammation. That turned out to be quite a difficult charge for us, and we didn't quite do that. But the bottom line was that at the time we did this, and I think the statement is still true actually, that clear recommendations on which biomarkers of inflammation to use and how to interpret patterns of biomarkers and changes in inflammatory biomarkers are lacking. And therefore we set about trying to make some progress in that area. So what we did was we identified general and disease-specific markers of inflammation within the circulation and within tissue sites. To do this, we considered a range of inflammatory conditions, some of which I've already mentioned to you. These were inflammatory conditions related to metabolic stress, to immune-mediated triggering, to allergic triggering, to neurodegenerative processes. And we identified plasma and serum markers, blood cell markers and tissue markers for each of the conditions we looked at. And then we looked for markers that were common across all of these conditions, because these must be generic markers of inflammation, irrespective of the trigger or the site of the inflammatory action. These are the markers that we came up with as being generic markers. They include all of the things that anyone interested in inflammation is already measuring, like C-reactive protein, interleukin-6, and what have you. So actually there was nothing new, I don't think, in this listing. We also highlighted blood cellular markers that are generically associated with inflammation, but again, there's nothing new there. One of the things that we did note was that whatever marker you look at, and if you make that measurement in a number of people, and these could be in healthy volunteers or in people with disease, you get a wide variation in the measurement in both the soluble markers and the blood cellular markers, even if people are healthy. And one of the reasons for that variation, of course, is that we have modifiers. So there's an inflammatory trigger that initiates the pathway, that initiates the response, which here is manifested as the measurement of particular inflammatory markers in the bloodstream. But given this path, how can you end up with a wide variation in the outcome, the markers? And the reason is the presence of these modifiers. So things like age, body weight, physical activity, sex, genetics and epigenetics, smoking, gut microbiota, diet, use of medications, emotional stress, sleep behavior, all of these things have been demonstrated to have an impact on inflammatory marker concentrations in the context of a particular specific trigger. So, in other words, you have to take account of these modifiers in your study, or in fact, you might want to study the effect of the modifiers themselves. The other thing we highlighted is that although most studies measure inflammatory marker concentrations in typically fasting blood concentrations, because that's what most of us like to use in our studies, the inflammatory response is dynamic. So this is the response to bacterial endotoxin over time, showing that you get a very rapid rise in TNF concentration. Later on, IL-6 comes up. Later on, IL-10 comes up. So if you want to get a real picture on the inflammatory response, you have to take into account this temporal nature of the response. So if you have an interest in interleukin-10, for example, it's no use measuring interleukin-10 here because the concentration is low, and you would say, well, there isn't much interleukin-10 associated with my response, and my special nutrient has no impact on interleukin-10 concentration. If you're interested in interleukin-10, you want to be out here somewhere. Conversely, if you're interested in TNF, you want to be here somewhere, and measuring TNF out here is not going to be very helpful to you. So the point is just to recognize this dynamic response of inflammation, and maybe in the context of the things that we're interested in, many of which are on this list of modifiers, some might be on the list of triggers, we have to think about this dynamic response. So there's lots of challenge models that can be used to initiate inflammation in a controlled way to be used in experimental conditions. So we felt that using a challenge model and looking at the dynamics of the response could be very useful. And these are the challenge models that are discussed in the article: an oral glucose load, an oral fat load, acute exercise, a full-blown inflammatory trigger like bacterial endotoxin or TNF, ultraviolet exposure, and vaccination. Now, all of these models have been and are being used in nutritional experiments right now. So you could find papers where people have looked at the effect of nutrition or nutrients, and all of these models have been used. So, for example, there are studies on micronutrients and polyphenols and the inflammatory response to UV irradiation using controlled UV irradiation on the skin of people. Bacterial endotoxin models have been used, for example, in studying the effect of omega-3s on inflammation. So I think this is a reality and is going to really take hold. What's really interesting is if you just give people a high-fat diet, a high-fat meal, the sort of thing I had for breakfast this morning just along the road here at the hotel, and take serial blood samples over the few hours thereafter, you get an elevation in TNF, in IL-6, and so on. So simply eating a high-fat meal induces an inflammatory response, and you could monitor that in an experimental situation if that's what you wanted to do. So I think this is almost the bottom line of what we decided, that a combination of multiple markers, so clusters if you like, patterns, and integrated readouts based on a temporal analysis following a controlled challenge will probably be the most informative thing that we will be able to develop to look at inflammation in the context of nutritional exposures. So far what I've told you is that inflammation is a normal physiological response to challenge, stress or injury. Where it's not controlled, tissue damage can occur, and uncontrolled or inappropriate inflammation underlies many common conditions and diseases, although the role of inflammation can be silent in some of those. Inflammation involves a common set of pathways, cells, and chemical mediators, and changes in many of these can be measured to monitor inflammation. There isn't a single marker of inflammation, so you can't measure one thing that will tell you everything you want to know about a person's inflammatory state. You can measure one thing and say they're inflamed, perhaps, but that won't give you everything that you're interested in. There's a lot of variation in markers of inflammation because of the presence of these modifiers. Inflammation is dynamic, and in nutrition and lifestyle research, challenge models are likely to become increasingly important. And actually, we're seeing that in the literature right now. So what about diet and foods and nutrients and even non-nutrients as modifiers? So in fact, I happened to be on another pan-European panel that addressed this question in the context of overweight and obesity. So here we were charged with identifying the role of diet and dietary factors in low-grade inflammation. So how can nutrients, non-nutrients, food components impact on inflammatory processes? So I think there are at least 5 different possibilities. There are probably more, but when I made the slide I could think of 5. They could be involved in induction of damage or stress, which could include oxidative stress. They could be intimately involved as a precursor of something involved in inflammation. So examples would be arachidonic acid and eicosanoids, arginine and nitric oxide, oxygen and superoxide. These would be examples. They could be involved in regulation of inflammation somehow. A good example could be some of the antioxidants, omega-3 fatty acids. They could regulate membrane events, signaling, transcription factors, gene expression, so some of the polyphenolic compounds might be important there. And they could protect against damage, and that could include oxidative damage. So there's a whole range of different things. So what people are eating is a modifier to this process here. Of course, many people, including people in the room, have looked at the relationship between foods and food components, both nutrients and non-nutrients, and inflammatory outcomes. And people have done these studies in many different ways. Of course, they've looked at the relationships between patterns of intake, between the relationships between nutrient status, and they've done interventions changing exposures and looking at outcomes. So this is... I wouldn't want to be held on my life for this table, but this is, when I was asked once to come up with a table like this is what I did. Pro-inflammatory components would include things like advanced glycation end products and advanced lipooxidation end products, so damaged materials in foods, oxidized phospholipids and oxidized cholesterol, perhaps some saturated fatty acids, trans fatty acids, and there's a discussion about omega-6 polyunsaturated fatty acids, which is why I have the question mark there. On the anti-inflammatory side, of course, many of the vitamins, many of the trace elements, omega-3 fatty acids, short-chain fatty acids, many of the polyphenolic compounds, sulfur-containing amino acids, some prebiotic-type carbohydrates, and perhaps probiotic bacteria would be on that side. So you can imagine in a mixed diet, you're getting a range of modifiers, so what you end up with is going to be the summation of everything that's going on there. But what it means is that by changing diet or nutrient exposures, you might be able to modify inflammatory processes in both people with frank disease, in people with silent disease, and in people who don't know about either of those. So I just pulled out a couple of studies here. These are on the Mediterranean diet, looking at the relationship between adherence to the Mediterranean diet and various inflammatory markers. So this is a higher Mediterranean diet score going across here, showing a significant reduction in a range of inflammatory markers, including whole cell count, some acute phase proteins, some cytokines, and adherence to the diet. This is Mediterranean diet score here, and the relationship with interleukin-6 and CRP, showing the greater the Mediterranean diet score, the lower the concentration of those two inflammatory markers. This is from the Nurses' Health Study, showing the relationship between an increasingly prudent diet, so these are the quintiles of an increasingly prudent diet, associated with a significant reduction in CRP, soluble E-selectin and soluble VCAM1. The other two markers, IL-6 and ICAM1, weren't significantly associated. So these studies suggest that a healthy diet is associated with lower concentrations of inflammatory markers in the bloodstream. And of course, that is related to the foods within the diet and to the nutrients and non-nutrients within those foods. Of course, the opposite must also be true, that an unhealthy diet must be associated with higher concentrations of inflammatory markers. Now, it's actually quite hard to find data on unhealthy diets in the way that I've just showed you data on healthy diets. But again, from the Nurses' Health Study, they did show actually in the same table as the prudent diet, the information on the quintiles of adherence to a typical Western diet, which was defined by the presence of a range of unhealthy dietary choices. And what this showed was that actually for, this is not significant, but it's going the right way, but for the other four of these outcomes, the relationship was significant in that the greater the adherence to a less healthy diet, the higher the concentration of these inflammatory markers. So given that, if you take people and change their diet, can you impact on inflammation? So this is early data from the PREDIMED study, which some of you will know was this big intervention with two types of Mediterranean diet, one characterized by high use of virgin olive oil and the other characterized by significant use of nuts. And interestingly, I mean, one of the problems with this study is it doesn't have a really good control group. The control group in this study is actually a low-fat diet. And, you know, if we went around the room, probably half of the people here would say a low-fat diet is actually a healthy diet. So that's the control diet anyway. So these are the changes in CRP, interleukin-6, ICAM1, and VCAM1 in the two Mediterranean diet groups. This is over 3 months, 275 people per group, so this is a pretty big study. They were all overweight or obese, and half of them were diabetic. So in the Mediterranean-style diet with olive oil, CRP dropped, ICAM1 dropped, VCAM1 dropped, and interleukin-6 dropped. So this is, I think, a fairly convincing anti-inflammatory effect of that diet. The Mediterranean diet with nuts, no change in CRP, but a reduction in ICAM1, VCAM1, and interleukin-6. So I think that's looking positive as well. And then the low-fat diet, no change in CRP, no significant change in IL-6, but increases in ICAM1 and VCAM1. So this shows an increase in 2 out of 4 inflammatory markers in people put on a low-fat diet. Now, of course, you could say, what were they eating instead of the low-fat? And maybe that was increasing inflammation. So I think that's the answer to what's going on here. So what I've told you in this bit is that nutrients and non-nutrient components of food may exert a variety of actions to influence inflammation. Many types of study have been performed to unravel the nutrition-inflammation axis. Healthy diets and the food, nutrient and non-nutrient components of healthy diets are associated with less inflammation. What I haven't said, but I think it's evident, that mechanisms of action of these are at least partly understood. But again, most nutrition studies have assessed static markers of inflammation in fasting blood. So I think the challenge models could be useful here. So the last part of the talk is about some of our work, some recent and some not so recent, on omega-3 fatty acids, particularly the long-chain, highly unsaturated omega-3 fatty acids, EPA and DHA, found in fatty fish and in fish oil type supplements. Many of you, of course, will be familiar with these fatty acids. Just for your information, I think this is 2013, and this is a review which just came out in 2015. So these are two up-to-date review articles in the area of omega-3 fatty acids and inflammation, if people are interested in finding out a little bit more. This is the working model that we've used over a period of more than 20 years now in our studies of omega-3 fatty acids, immunity, inflammation, and wider disease risk. So our proposal is that by altering EPA and DHA supply, either through diet or supplementary means, we alter the composition, the fatty acid composition of cell membrane phospholipids. This impacts on the physical nature and the structure-function relationship within cell membranes. This impacts on signal transduction pathways that ultimately alter gene expression, and it also impacts on the pattern of bioactive lipid mediators, prostaglandins, leukotrienes, resolvins, and all of those things that are produced by the cells. So the cells themselves behave differently in response to a particular inflammatory trigger, and because the cells are responding differently, ultimately the response will be different. So in terms of mechanisms within the membrane, this is a picture from one of those reviews, just showing that although we have focused for a very long period of time on the importance of changing the fatty acid composition of membrane phospholipids as being the center or the focus of how these fatty acids are influencing inflammation, because once they're in the membrane, they can affect how proteins are behaving in the membrane, they can affect lipid mediator production, they can affect responses to prototypical inflammatory stimuli like bacterial endotoxin. And I think all of that still holds, but there are data suggesting that free extracellular omega-3 fatty acids can also impact on inflammation, acting through G-protein coupled receptors, some of the fatty acid receptor families. So perhaps there are also receptor-mediated actions of omega-3 fatty acids that are important in controlling inflammation. So putting all this together, it seems that changing omega-3 fatty acid exposure alters membranes, which impacts on lipid rafts, membrane fluidity, availability of substrates for lipid-mediated synthesis. There are also these G-protein coupled receptors. So through all of these mechanisms, we're changing signals within the inflammatory response, intracellular signals and extracellular signals. So the cells are responding differently, neighboring cells are responding differently, perhaps distal tissues are responding differently. So we can impact on both the physiology and the pathophysiology, and hopefully this has an impact on improving health or making clinical outcome better. So I just want to give you a couple of examples where we've investigated this. The first one is in this area that I alluded to earlier on, which is in acute cardiovascular events. So before I showed you this slide where macrophages and T cells within the vessel wall are interacting and producing matrix metalloproteinases that degrade the fibrous cap on the atherosclerotic plaque, making it vulnerable to rupture. So in 1999, the Gissi Prevenzione trial, which many of you will be familiar with, was published. This was a big randomized controlled trial of omega-3 fatty acids in patients who had recently had a myocardial infarction but survived. And they were followed up for 3.5 years, and this is the relative risk reductions in the patients receiving omega-3 fatty acids compared to the placebo group. So these are all significant reductions, including a 45% reduction in sudden death. The pattern of these mortality outcomes, total mortality, sudden death, coronary heart disease mortality, and cardiovascular mortality, over the first year of the study is shown here. And what this plot shows is that the two groups, that is the omega-3 group, which is the top line, and the control group, diverge quite early on. And the effects on these outcomes become significant in perhaps as short a period of time as 3 or 4 months. So even though the study was 3.5 years long, some of the outcomes were already significant after 3 or 4 months, including total mortality and sudden death. This is the cartoon I was mentioning, where the inflammatory cells play a role in increasing vulnerability of plaques to rupture by degrading the fibrous cap and thinning it. So a thin plaque cap with a heavy infiltration of inflammatory cells make plaques more likely to rupture. So we reasoned that since omega-3 fatty acids are anti-inflammatory, the explanation for the findings of the GISI Prevenzione trial were that omega-3 fatty acids had got into plaques, had stabilized the plaques, and had prevented their rupture. And if the plaques don't rupture, you don't get the mortality. You don't get the sudden death. So we wanted to explore that, and we were able to do that by taking advantage of a surgical intervention, which is surgical removal of atherosclerotic plaques from the carotid artery. The procedure is called carotid endarterectomy. So the carotid artery is exposed, it's clamped off, it's sliced open, and the plaque is pulled out. Okay. So we took. So there's a few things. The plaques are quite large, as you can see. Secondly, this operation is extremely common, so there are a lot of people around who are going to have the operation. And thirdly, in our health system, particularly when we did the first study that I'm going to tell you about, patients have to wait a long period of time before they have the surgical intervention. And of course, what that means is we can do nutritional interventions while they're waiting for surgery. So we undertook a randomized controlled trial of omega-3 fatty acids with the outcomes being plaque stability, plaque morphology, and plaque composition. We published the main findings from the study quite a long time ago now in The Lancet in 2003. So what we showed, so this is a randomized controlled trial in 180 patients awaiting carotid endarterectomy. They were treated with one of 3 oils, one of them being an omega-3 fatty acid containing oil at 1.6 grams of EPA plus DHA per day. So what we showed in the study for the first time ever was that giving people omega-3 fatty acids means that they end up with plaques that are enriched in omega-3 fatty acids. And this happens quite quickly. So even though some of these people were 80 years old and had been building up plaques for about 79 years, within a matter of weeks to months, we can change the composition by getting omega-3 fatty acids in. They had fewer macrophages within the plaque. And also, the stability of the plaques at surgery, which was analyzed by a cardiovascular pathologist who was totally blind to what was going on. So if the patients have received omega-3 fatty acids, they were more likely to have stable plaques. They were less likely to have unstable plaques. As I've said already a couple of times, matrix metalloproteinases are very important in this thinning of the cap. So what we had identified is fewer macrophages and a more stable plaque with omega-3 fatty acid treatment. We were interested in whether omega-3 fatty acids stabilize plaques through reduction in matrix metalloproteinase activity or matrix metalloproteinase burden. To do that, actually, we had to do the whole study all over again because we didn't have any more plaque material. But we got a grant to do the whole study all over again, so that was good news. So these are matrix metalloproteinase and other inflammatory markers within the plaques of patients who had taken vegetable oil or omega-3 fatty acid until surgery. And the key thing for you to see is simply that the MMP burden is much lower if the patients had taken omega-3s compared to not. So what we showed in these 2 studies is that by giving omega-3 fatty acids, you have more omega-3 fatty acids in advanced atherosclerotic plaques, that this is associated with fewer macrophages, with fewer foam cells, and with fewer activated T cells, with lower expression of certain inflammatory cytokines, and with lower levels of matrix metalloproteinase messenger RNA. So we concluded there's less plaque inflammation, increased plaque stability, therefore people don't have events, people don't die. The second thing to talk to you about, just briefly, is non-alcoholic fatty liver disease. So this is accumulation of fat exceeding 5% by weight in the liver in the absence of significant alcohol intake. The condition, NAFLD, has a wide spectrum, going from simple lipid accumulation all the way through more serious conditions right up to cirrhosis. So here you see the presence in the fatty liver of these lipid globules which are absent in the normal liver. This disease has a prevalence in the normal adult population of about 30%, so 1 in 3 adults have NAFLD. One of the main risk factors for NAFLD is obesity, and therefore the prevalence of NAFLD is going to increase. Having NAFLD can lead to progression to the more serious forms, requiring liver transplantation or associated with liver cancer. But NAFLD is also a risk factor for cardiovascular disease, and that's being increasingly recognised. The condition obviously involves some alterations or abnormalities in lipid metabolism with the accumulation of triglycerides. There's also an involvement of inflammation, and that role of inflammation seems to be important in progressing simple NAFLD to more serious conditions. Oxidative stress and mitochondrial dysfunction are also involved, but I think these things are part and parcel of the inflammatory response. Because of the effect of omega-3 fatty acids on inflammation, we reasoned that they might improve NAFLD through targeting hepatic lipid metabolism and hepatic inflammation. So just in about October of last year, we published this paper in Hepatology reporting the outcome of a randomized controlled trial in 100 patients with NAFLD, half of whom were randomized to high-dose prescription-grade omega-3 fatty acids, giving them 3.6 grams of EPA plus DHA per day. This was a long intervention of 18 months. So it's a high-dose, long intervention, so we were optimizing the likelihood of finding an effect. The primary outcome was liver fat measured by magnetic resonance spectroscopy. Patients given omega-3 fatty acids showed lower plasma triglycerides, lowered blood pressure, and a few other things. The main finding is the liver fat. So this is change in liver fat from study entry to 18 months of treatment. So this is absolute change in liver fat. So this is end minus start. And this is relative change in liver fat, end minus start divided by starting proportion. Whatever way you look at it, liver fat was decreased in patients taking omega-3 fatty acids compared to control. In the study, we showed marked incorporation of both EPA and DHA into plasma and into red blood cells. Of course, you would expect that. But we did see a highly variable enrichment of EPA and DHA in red blood cells. So we did multiple regression analysis to try to find out what the predictors of the reduction in liver fat would be. So in this multiple regression analysis, we have age, sex, body weight difference, starting liver fat, this marker of apoptosis, and enrichment in DHA in red blood cells as the predictive factors. And 3 of these came out as being significant as independent predictors of loss of liver fat. One of them was body weight change. The second was starting liver fat. So the more liver fat you start with, the more you lose. And the third, with P of 007, is enrichment in DHA. So the greater the enrichment in DHA in red blood cells, the greater the loss of liver fat. At the time we were writing up our data, a paper came out. So this didn't come out for the other omega-3 fatty acid EPA. So this is a DHA-specific effect. So this paper came out using DHA to treat pediatric NAFLD. This is an Italian group. And what they demonstrated was a reduction so they did liver biopsies before and after treatment. We didn't do biopsies. They showed that DHA decreased liver fat, decreased ballooning of hepatocytes, and decreased the inflammation in the liver. These were all highly statistically significant. And then just last month, this paper came out on omega-3 fatty acids in NASH, so this is slightly more severe NAFLD, showing that omega-3 fatty acids decrease liver fat from 12 to 8%. So that's an absolute reduction of 4%. and a relative reduction of about 33% with omega-3 fatty acids. Just for your information, our patients started with about 35% liver fat on average. So we were starting much higher than this. We haven't published this. I can't tell you what it means, but it's just to show you. So this is the plasma proteome in some of the people from the omega-3 group and some of the people from the placebo group. So we're getting big changes with up and down regulation of proteins in the plasma with the treatment. 15% of patients were modulated. The last thing to talk about just briefly is obesity. So if you look at obese people and measure classic inflammatory markers like CRP, interleukin-6, this is the sort of picture you get. So these are P-selectin, IL-6 and TNF in obese compared to non-obese women. So there's about a doubling of inflammatory markers in these obese women compared with normal weight. This is the relationships between markers of body fatness, waist-hip ratio and body mass index, and 5 different markers. So these are positive, these are the correlation coefficients, they're all positive relationships, and they're all statistically significant. So the more obesity, the higher the inflammatory markers. They put these women on a weight loss regime which involved change in diet, exercise, and dietary counseling. And the 3 inflammatory markers shown in the graph were all decreased from the starting value, which is the left column, to the post-intervention value, which is the middle column, which is pretty much the same as normal weight individuals. And then here we see the relationship between the change in body mass index, the change in waist-hip ratio, and the change in each of these 5 inflammatory markers. And again, these are the correlation coefficients, and they're all significant. So the greater the change in indicators of obesity, the greater the change in the inflammatory markers. So there's a very tight relationship between inflammation and obesity. So we've been a bit interested in this in a recent study that we've done. So I just have 2 slides to show you this interesting finding that we happened to make. So we were looking at toll-like receptor 4 expression on monocytes in normal weight and obese individuals. Toll-like receptor 4 is the receptor for bacterial endotoxin, that stuff that killed the mice in the very early slide that I showed you. So this is percentage of monocytes expressing toll-like receptor 4 in the bloodstream of normal weight and obese people, and then this is the level of expression of the TLR4 on the positive cells. So what we identified was that obese people have more TLR4 expressing monocytes in their bloodstream, and if they're expressing TLR4, they're expressing more of it. So these cells are really primed to mount an inflammatory response if they encounter bacterial endotoxin. Now, you could argue that's a good thing, you could argue that's a bad thing. This is the observation. I told you before that we're very keen on challenges, so we've been using a high-fat breakfast as a challenge to trigger inflammation across the postprandial period. So we gave people this breakfast that has 1,100 kilocalories, 85 grams of fat, including 58 grams of saturated fat, and we took serial blood samples out to 6 hours. This is TLR4 expressing monocytes and the area under the curve this is total, not incremental area under the curve. In normal weight people, so there's no difference, but in obese people, there's an elevation in TLR4 expressing monocytes once they eat that high-fat meal. Again, we don't know exactly what that means, but obese people are mounting a different inflammatory response to a high-fat meal compared to normal weight people. We looked at the effect of omega-3 fatty acids on this. It didn't make any difference whatsoever, so I'm not going to show you that rather disappointing slide. So this is the summary of the last bit. Human inflammatory cells contain a lot of arachidonic acid, which is a precursor of inflammatory cytokines. I didn't actually show you that. Omega-3 fatty acids get into inflammatory cells easily. I didn't show you that, but there are a lot of papers on that. When they get into the membrane, they affect all sorts of things related to the membrane, intracellular signaling, gene expression, and the pattern of lipid and protein mediators that inflammatory cells produce. Through these effects, omega-3 fatty acids affect inflammatory processes, inflammatory cell responses. I think omega-3 fatty acids are anti-inflammatory, at least using the readouts that we've been using. And they do that actually not just in a test tube, but in whole human bodies. And this might be really important in reducing cardiovascular events and mortality, delaying progression and reducing complications in people with NAFLD and obesity. So I think this sort of work, all the way from molecules to cells, through animals into people, has some clinical relevance. Thank you very much for listening.
Are there questions?
The last study that you showed us your disappointment over the fact that omega-3s didn't seem to attenuate that effect you were looking at. I'm wondering whether you're willing to speculate as to why you got a null result. Is there something idiosyncratic about the inflammation that's associated with obesity that distinguishes it from other types of inflammation?
Yeah, so in this study, we examined responses to a test meal, if you put omega-3s in the test meal or not. And we also examined the effect of a period of 3 months of chronic intervention with omega-3 fatty acids on the response to the test meal. And we did that in normal weight people and in obese people. Okay? So in the normal weight people, we found that both putting omega-3 fatty acids in the meal and a period of chronic intervention with omega-3 fatty acids had several impacts. In the obese people, we didn't see that. So given the same dose of EPA and DHA, the obese people were resistant to the effects that were demonstrated in normal weight people. But they did show good incorporation of the fatty acids into plasma, into red cells, and so on. So I think, I think your question almost gives us the answer in the way you phrased it, that at the dose given and the readouts that we used, we don't see anything in obese people with omega-3 fatty acids. So whether they're not having an effect or whether we're not just looking at the right metabolic and inflammatory outcomes, of course we can't say. Maybe they need higher doses. That would be part of it.
Just following up on that, could it have to do with the type of challenge that you use that other types of inflammatory challenges you might see?
Yeah. So we measured, in response to this high-fat meal, many things: cytokines, chemokines, cell markers, many things. Of course, and some of those things change in response to a high-fat meal, some of them don't. Now, if you gave an endotoxin challenge, of course, you would see both a different magnitude of change, a different timing of change, and maybe you would see different things coming up and going down. So I think you're right, that different challenges will tell us different things, for sure. And therefore you might come to different conclusions about the effectiveness of an intervention, for sure.
Thank you, Phil. That was very nice talk. I had two quick questions, but the last study, now I have three quick questions. So in the last study, you showed, I haven't actually seen before, you showed a rise in, I don't know if you go back to the slide, but you showed a rise in the 1 hour effect compared to baseline. But then you showed that the high-fat meal is actually beneficial for inflammation long term, with going back almost to normal people. And so the area under the curve is a little bit misleading. It's starting out higher.
Yeah.
So separate from the omega-3 question, I've seen a lot of 1 hour studies, but you seem to be demonstrating that high-fat meals, which goes along with what I think is true, that high-fat meals are beneficial for people with obesity. There's an anti-inflammatory effect. So that's one question. I have two other.
So I think one thing that's important, which is again captured in your question, is that you've got to look at the right time frame. And I think people know a lot about particular time points with this sort of challenge, but they don't always go out to 6 hours. They don't always capture the 1 hour, all sorts of things. So I think there's something in that. I think the other thing, which is why I pointed out this was absolute area under the curve, is the incremental is going to be different from that. And actually, if anything, both of these groups seem to be going below the starting point at 6 hours. So, we haven't really dissected this in relation to triglyceride concentrations, for example.
That seems to be a my mind, a new and very important
Okay,
mind.
thank you. Yeah.
The second two questions were in your summary too, where you
Oh.
reviewed the literature of nutrition
Yep.
and biomarkers.
Yeah.
Did you come across that review in two questions? One is the beneficial effects of inflammation. So, for example, there was a trial of vitamin E supplementation and statins showing that if you give vitamin E in people who are, vitamin E and exercisers, and if you give vitamin E to exercisers, you abolish the inflammation to exercise training, but that abolishes the positive response of insulin sensitization. And so when we're doing these studies and looking at these nutrient molecules and inflammatory outcomes, maybe the response goes up or down, but that's a bad or good thing.
Yeah.
in different
So
directions.
I think it's really hard to interpret what increases and decreases in many of these things mean in people without a frank disease. So, of course, if you have someone with a chronic inflammatory condition that's pathological, you treat them by dampening the inflammation. Now, of course, there is a deleterious consequence of that sometimes, like increased susceptibility to infection, for example. So I think you're right that although one always starts from the point of view that inflammation is bad and we should dampen it, that's too simplistic. I do agree with you. We didn't talk in the article, as far as I can remember, about this philosophical aspect, but I think it is a very important point you make, for sure.
And then, again, the third very brief question is, did you find in your review, do people who have a high acute response tend to be people who have a high chronic response, or vice versa, maybe people with high chronic response have a down acute response, or is there no correlation?
We didn't look at that, and I don't know, you might know because you're asking the question whether there's data on that, but I think it's an interesting question. We don't know.
Really interesting seminar. I guess I'm trying to understand your views on fat in the diet. Do you think it's the amount of fat or the type of fat? Because you alluded to the low-fat diets in the Mediterranean diet study. They were 30% fat. So
They're not exactly low.
Right. But, and I don't think any most of us would be recommending low-fat diets anyway. But then you're using a high-fat diet as a challenge. Where are you coming down on these issues?
Well, certainly I think the type of fat or the quality of fat, the fatty acid composition of fat is extremely important. And I think overall that's probably more important than the amount of fat. I mean, that's really my feeling. And I think I'm becoming convinced actually that lowering fat too much is not desirable when we're replacing fat with carbohydrate. I think that has deleterious consequences.
To what extent the lack of anti-inflammatory response in the bees could be based on the lack of conversion of omega-3 fatty acids into resolving type molecules? I think very simply whether this omega-3 possibly is partitioned into the fat and preventing the possibility that the anti-inflammatory molecules can be.
So we, just for your information, we have taken fat biopsies from people before and after omega-3 fatty acid intervention. We did that in this normal weight and obese subject study. So obese people do lock away omega-3s in adipose tissue. And you could, so we gave everybody a standard dose, which I think was 1.8 grams of EPA plus DHA per day. So you could argue that obese people, because of the greater amount of adipose tissue, are locking more of that away in adipose tissue than normal weight people. So we have data that would support that idea. So that would stop the omega-3s from having systemic effects, which actually might be part of the reason for why they're relatively ineffective systemically. So that's a helpful thought for me. But you ask about inflammation in adipose tissue. So if you want to control inflammation in adipose tissue, you want the omega-3s to be there. Now, what some people recently have demonstrated, so it's Swan Claria working with Sirhan, has demonstrated that resolvin levels in adipose tissue biopsies from, I think it's people with metabolic syndrome, it could be obese people, I can't remember, are lower than healthy people. So that fits actually with your contention that part of this ongoing low-grade inflammation is lack of the controlling, resolving factors. So I think, there's something in it. Yeah.
Resolving, just a little addition to this, sufficiently stable to be used as a supplement?
Well, if you talk to anyone who measures resolvins, the first thing they will tell you is, oh, these are very unstable. That's why they're so hard to measure. But then there are people who are interested in your approach, which is, putting resolvins in a pill and giving them to people. And of course, there is at least one company that's trying to, or is actually trialing stable analogues of resolvins for use in oral applications. So I think, people are thinking along those lines. Yeah.
Other questions?
I'm curious about the effect of the activation of PPAR alpha or PPAR gamma, and whether the DHA is affecting oxidation of fatty acids in the liver.
Yeah. So there are data, particularly from animal models, rodent models, showing that omega-3s and DHA in particular is a PPAR alpha inducer, and people have related that to improvements in models of deposition of hepatic fat, particularly in mice. Now, so that could be part of the story. There's also data on PPAR gamma and omega-3 exposures, suggesting that could be part of, an insulin sensitizing effect in adipose tissue. This has been demonstrated mainly in cell lines and in mouse models, not so much data from humans. But, maybe PPARs are part of the picture of sort of the whole body effects of omega-3s in controlling metabolic processes, insulin sensitivity, and inflammation.
Is there any effect on TOR levels and TOR activity, of omega-3?
I can't tell you because I'm not so familiar with the literature in the area, but I know there are data looking at skeletal muscle responses to amino acids where people have combined amino acids with omega-3 fatty acids and got better effects than the amino acids alone. So certainly there's an interaction there. Whether that involves mTOR, I'm not sure.